participate in the Q&As, the polls throughout this presentation, because it will definitely help shape what we're doing over the next 5 years. Let's move on to the next slide. This will be good for me. It's a little background. So if you could use the Menti app to inform me if you've ever heard of our organization. I was there for a minute. Well, I'm at least excited to see that 3 people have, well, 4 now, have heard of the Dmhc. That's promising. Typically, that isn't the case. There are quite a few that don't know of the Department of Managed Healthcare. So maybe I'll give some information you don't know about. And for those who have never heard of us, hopefully this will be very interesting and usable information. Generally, I'm not a fan of putting a lot of words on slides and then reading them to you. But in this case, I thought it was important to do that because this can be used as reference material after the presentation. Ooh, I think we're getting some feedback there. Thank you for muting. All right, let's move on to the next slide. So I just want to walk through our mission statement. The California Department of Managed Healthcare protects consumers' healthcare rights and ensures a stable healthcare delivery system. I just don't want to leave it there. I want to break that down into the 2 components. Protects consumers' healthcare rights. What does that mean as an individual consumer? And what that means is the authority that we're granted for our regulatory oversight is through the Knox-Keene Healthcare Service Plan Act of 1975. And its applicable regulations through Title 28 California Code of Regulations. And so protecting healthcare consumer rights, and I'll get into this a little bit further in the broad sense of what we do at the Dmhc, but we have the most sophisticated in the country state-run consumer assistance center. And we address, it includes a contact center for calls, as well as addressing complaints and independent medical review requests. And so that's how we are protecting your rights afforded to you through your contract or your evidence of coverage with your health plan. The second component of this is ensuring a stable healthcare delivery system. Now, what does that mean? That is the financial component. If a health plan or its delegated medical groups do not have enough money to pay claims, this creates instability in the healthcare delivery system. A couple of quick examples would be if a health plan or a medical group is running out of funds, one of the first things that they do is they stop authorizing services. So in most managed care plans, you have to have an authorization in place before you can obtain a service. Well, if these groups don't have enough money to pay for those claims, their first step is to deny more requests for authorization. That's one of the first tip-offs for us. That impacts consumers directly by not being able to get those services. Subsequently, if they don't have enough money, they won't pay their providers. And how that destabilizes the healthcare delivery system is if providers aren't getting paid for the services they've delivered, they may stop seeing patients from that particular health plan or medical group. Now you've got a decreased number of physicians or providers that will provide care to enrollees. And that is another kickoff for us to show that there is a likely solvency issue with a health plan or medical group. So moving on to the next slide. So what is the Dmhc? The Dmhc is a regulatory authority or agent department, and we regulate full service and specialized health plans in California. As you'll note on the slide, we have jurisdiction for 26.4 million consumers in California. They're enrolled in at least one health plan under our jurisdiction. I looked up this morning, and the population of California in 2019 was 39.5 million. So we're talking 2/3 of the population in California are enrolled in a product that's under our jurisdiction. And this is why it's so important for us as a department to get information out to those 26.4 million consumers who may be experiencing challenges with their health plan. So what do we regulate? All HMOs and some PPO and EPO products, some large group and most small group and individual products, most of the Medi-Cal managed care plans, and then specialized service plans, which are dental, vision, behavioral health, chiropractic, and prescription drugs. In the Medicare world, we have very limited jurisdiction, and that is over Medicare Advantage, and that is for financial solvency only. All other issues related to Medicare Advantage are handled by the Center for Medicaid and Medicare Services, CMS. All right, let's move on to the next slide. So I want to talk briefly. So we talked about the 26.4 million people that we regulate, but there are some people who have coverage that are outside our regulation. And those entities or products are under California Department of Insurance. So some other of the PPO products or health and life products are not under our jurisdiction. Most Medicare coverage, as I outlined before, is through CMS. Some Medi-Cal coverage, the fee-for-service, the limited fee-for-service enrollees, as well as the county-operated health systems are not currently under our jurisdiction. There has been proposed legislation in the past that hasn't gone through that would give us the authority to regulate those county-operated health systems. Another self-funded area is ERISA, the Employee Retirement and Income Security Act of 1974. Those are self-funded plans, usually employer group plans, and those are not under our jurisdiction. And then also private health benefit exchanges. Next slide, please. Let's do another quick poll. What has your experience been like when working with your insurance plan? Angela, I'm not sure if we have canned answers for this or this is a Q&A component.
Oh, it should be a fill in the blank. Let me see.
Okay.
Yeah, so those, yeah, there we go.
Okay, well, that's promising to hear. It makes me think we're doing a pretty good job for those new to the system, okay? All right, well, that's more promising than I expected. All right, let's move on to the next slide. So what does the DMHC do? What are our key functions? So as I've noted before, we're a consumer protection, and that is through our department's help center. And I'll get more into that in a few more slides. We also license health plans, ensure compliance with state law. So one of our offices, the Office of Plan Licensing, reviews all new applicants for licensure under the DMHC. We ensure that they have filed all the required paperwork, policies, procedures, evidence of coverage and whatnot before we will approve and grant a license to a health plan to operate in California. And the third bullet here is medical surveys of health plan operations. That is done out of my office on a routine basis, and every 3 years is the routine basis for that. We conduct on-site surveys or audits of health plan operations. And we do that in a variety of areas, grievance and appeals, access and availability, prescription drugs, emergency access, and those services, as well as a few others. And when we do that, after our on-site portion of that survey or audit, we produce what we call a preliminary health preliminary report. And we submit that preliminary report confidentially to the health plan, and we give them 45 days to provide us with a response, either that they don't agree with the deficiencies we found, or that they are putting in a corrective action plan that will correct the deficiencies we found. We then review the health plan's response and produce a final report, which is available on our public website. If at the issuance of the final report, there are deficiencies that have not been corrected, we then schedule and conduct within 18 months of the date of the issuance of the final report, a follow-up survey. And at that point, we take another look back period and assess whether or not the health plan's corrective action plans have effectively corrected the deficiency we noted in the earlier final report. If they haven't corrected those, we refer those to our Office of Enforcement for further review and potential penalties. The next area is financial exams. We talked a little bit about solvency and stability. We have an Office of Financial Review, and they review not only health plans, but medical groups to ensure that they are financially stable. That Office of Financial Review also reviews proposed premium rate changes in the individual and small group products currently. And if we find that a rate increase is not justifiable, we'll inform the health plan of that. And when we do that, in most cases, the health plan will come back at a lower premium rates for the next year's charging of premiums to enrollees. So it's been, although we can't stop them from increasing them currently, that exchange that we've had with them through this process has saved a significant amount of money for consumers in California over the past 5 years. Our Help Center also tracks enrollee complaints as part of our survey, medical survey or audit process. We reach out to each of the other offices within the Dmhc and ask for any concerns that they may have with respect to that particular plan. And we put that information into our medical survey and audit process when we're conducting our on-site audits. And I talked a little bit about our Office of Enforcement. If any office finds a health plan has not corrected a deficiency or is acting outside of the compliance of the Knox-Keene Act, we will refer those over to our Office of Enforcement for further review and potential penalties and further corrective action plans. All right, next slide, please. So this is probably very important to the folks attending today. Timely access to appointment standards. So I wanted to include this so everyone was aware of what the requirements of your health plan is in providing you or your family member or patient with a timely appointment to care. And so I think more specific to this group might be the urgent care, whether it be prior authorization being required or not required at 48 or 96 hours from the request of the appointment. And then the specialty physician for non-urgent, which is the fourth line down there, is 15 business days. So this would encompass a psychiatrist. The next line down would be for non-urgent mental health appointments. So any mental health provider who is a non-physician, it's within 10 business days. And I want to clarify a couple of things here. It's within these timeframes are within the requests that you make. That time frame in which you make the request, that's when the clock starts. And also another distinction I want to make is it doesn't have to be with a specific provider. The health plan is required to provide you with or offer you an appointment with an in-network physician, if available, or an out-of-network physician, if an in-network provider is not available, within these timeframes. It can be with any physician that's able to treat your condition, but it doesn't have to be specifically with one you're wanting. So I want to make sure we're clear on that, what the obligations of the health plan are. It's not a specific physician, but they have to get you an appointment within these specific timeframes. The only time that these timeframes can be extended is if your provider notes in the relevant record that going beyond these timeframes is not detrimental to your condition. All right, let's move on to the next slide. So what happens if you don't get an appointment within the timely access standard? The first step is to call the health plan for assistance. So the customer service representative number that is likely on each of your health plan ID cards. Most circumstances, the health plan customer service folks can assist you in finding a provider who can provide you with an appointment within the timely access standards that we went through in the previous slide. If for some reason the health plan fails to do that for you, you can contact our help center for assistance. And generally in these circumstances, we do what's called a quick resolution. We keep the enrollee or the consumer on the line. One of our help center employees stays on the line, and we contact the health plan representatives that we have access to, and we do a three-way call to resolve whatever that issue is. So in any circumstance, we are trying to resolve it in the fastest and lowest level we can, and a lot of these get resolved through this quick resolution process. If not, we may have to open a complaint or an independent medical review, which we'll talk about in just a few minutes. And the Dmhc, as noted, will ensure consumers receive timely access to care. Next slide, please. So this is one of those questions that is extremely important to me and that I referenced earlier with respect to agenda items 4 and 5. I don't want to get into it now because I want to save that till later later in the presentation, but just to give me a flavor of what barriers you or your loved ones have faced in attempting to receive services. I'll pause here and just see what responses we get.
Can I just speak?
Of course.
Because I'm having trouble trying to get onto everything electronic. But my name is Barbara Wilson, and I work and I advocate for a lot of people that have serious mental health issues. And one of the problems that I come into contact with my clients is they'll request, as a part of an HMO, for example, Kaiser, but not limited to Kaiser. So most recently, I have a lady who needs to be seen by a psychiatrist. She asked for the appointment, I know, a week or two ago, which was great for her to do that. They gave her an appointment, a video appointment. It's going to be in November. Now, this woman suffers from serious depression. They know that she suffers from serious depression. It was a big deal for her to even call for an appointment. And I'm really concerned that between September and mid-November, you know, there are a lot of options open to her, one of which is to gobble a bottle of medications. Another issue is how to have a therapist. She has Medi, which she gives to Kaiser, which is fine, but they've been somewhat, and again, I don't want to single Kaiser out like they're the bad guys, because this goes on in other health plans as well. Getting to have a therapist seems to be like reaching for gold. And then thirdly, we have primary care physicians who I think have administratively been advised to please not refer their patients to a psychiatrist because it costs the plan more money.
Thank you, Barbara, for that information. And I failed to mention earlier that I have 4 of my colleagues from my office attending this town hall as well. And they're not here to hear me speak. They are here to hear you speak. And they're taking notes as we go along. And again, I don't want to get ahead of myself because this is really going to be addressed in agenda item 4. But these are issues that I have heard in the past. It is concerning to me, Barbara, in your case for this individual not getting an appointment until November. I hear they're on Medicare, Medicaid enrollee, so I don't know if they're in the coordinated care, the CCI program, or they're separately using Medicare and Medicaid. But I would encourage you to have that person, or you on behalf of that person, contact our help center to see how, if in any way we can assist to getting an earlier appointment for that particular consumer.
Thank you. I appreciate that because I'm really concerned.
Yeah, as am I hearing that. November, that's way too far in advance for someone suffering with a mental health condition.
Oh. Thank you.
Thank you. So I think we may have had enough time for our folks to jot some of these down, but we'll revisit this here later in the presentation. But thank you all for providing this information to us.
And we can share this information after as well, Dan. We can send
I
these
appreciate
responses.
that. Appreciate that. That would be very helpful. All right. So again, I think an important component of this presentation is right here, our Consumer Help Center. What we do there, the 4 different branches within it, is dedicated specifically to assisting consumers. And the 4 different divisions within our help center are the contact center, which is the group of folks that take the calls. They are the initial contact for consumers. It's probably the most challenging job within our department because they have to be versed in a lot of different areas. They have a knowledge management system which they can access information very quickly to assist the consumer. They can refer consumers who are not under our jurisdiction to the right entity, either through a warm handoff or providing contact information to the consumer. They can assist consumers who are following up on an independent medical review or complaint they have filed. They are our first line folks in contact points for consumers. A really great group of folks. The second level is the independent medical review and complaint branch. So these are typically analysts who are reviewing independent medical review applications or complaints against a health plan. And so they are assessing that. We ask the health plan after receiving a consumer complaint, we send the consumer's complaint to the particular health plan and ask for them to respond within a very short period of time. We then review all the documentation and determine if the health plan was correct or incorrect in the way they handled that issue with the consumer. The next is the legal affairs branch. So they support not only the contact center, but the independent medical review and complaint branch. So if there's an issue with whether or not something is a covered benefit under the EOC, it's not clear in the EOC, these types of things are referred over to our legal affairs branch, where attorneys will either work directly with the health plan or directly with one of the analysts in the help center to answer that question. Is whatever the consumer is asking for covered under that contract with the health plan or evidence of coverage? And then the last is a provider complaint unit. So we've got to talk about consumers, but we also have providers. So we have a specific group, although a smaller group, that assists providers with any complaints they have regarding unfair payment patterns. So if providers are not being paid appropriately per their contract, aren't being paid at all, the health plan isn't responding timely to providers' complaints to the health plan, they can file complaints, providers can file complaints directly with our provider complaint unit. Move on to the next slide, please. So the health plan grievance process. So in most cases, before you can avail yourself to the services that are available free at our help center, you have to go through the health plan's grievance process. So first, if you have an issue or a complaint, you got to file that with your health plan. And we'll talk a little bit more in a slide or two of how you do that. If there's an immediate threat, now the caveat to that is there's an immediate threat to your health, you can come to the Dmhc without going to your health plan first. And so you can contact the Dmhc either through our contact center or filing a complaint with us. We then will review that to determine if it's appropriate for the health plan to handle first before you come to the Dmhc, or we may just take that on depending on the immediate threat issue that has been outlined in the complaint documentation. If you file a complaint with your health plan, you can do so over the phone, through the mail, or through the plan's website. So any of those ways you can file the complaint with the health plan. They have 30 days to review it from the time they receive it, either via phone, mail, or website, 30 days to provide you with their response to that. And if you are not happy with the plan's response in any way, shape, or form, or they haven't responded back to you within 30 days, you can then file a complaint or an independent medical review with the Dmhc. Moving on to the next slide, please. So the independent medical review. So I talked independent medical review and I talked about complaints. What's the difference? So an independent medical review is really to address health plan denials, modifications, or delays in a healthcare service based on medical necessity, or that the services that you requested are experimental or investigational. The other caveat, and we don't see as many of these, is if the health plan denies it, stating that the service you received were not urgent or emergent. So if someone went to an emergency room and received services, and then the health plan denies those, they might deny that based on that the services received were not emergent in nature. But the frequency of those is much less. The biggest bucket is the denial for not medically necessary, and I'm sure a number of you have heard that when requesting healthcare services through your health plan. What happens next? We take that documentation. Again, we send it to the health plan, the information you filed with us. We ask the health plan for a response. And in some cases, after receiving our request for information, the health plan will reverse their position. We call that a health plan reversal, and they'll authorize the services that you requested. If they don't, we review the documentation they sent and determine if it qualifies for an independent medical review. And then we send that out to an external organization that's independent of your health plan and independent of us. We just have a contract with them. And they assign that case to an appropriate provider. If it's a mental health issue, it might go to a psychiatrist. It may go to an ABA provider. For a surgical issue, it might go to an orthopedic or a general surgeon. So you have the right type of provider who's reviewing all of the medical records relevant to your condition, as well as your complaint documentation and the health plan's response. They are reviewing all of that in total to determine if the health plan's denial of your requested service was appropriate or not. In most cases, for non-urgent issues, those cases are decided within 45 days, and we provide you with the outcome of that independent medical review. Those are completed much quicker if it's an urgent case. In the case of cancer, of a severe mental health illness, someone who's in an inpatient setting, we will review those in a much quicker manner. If a complaint doesn't meet that medical, if it's not denied, modified, or delayed based on medical necessity, experimental, investigational, or non-urgent or emergent, we will process that as a consumer complaint. So the next slide, we'll talk about a little bit about what categories fall into the consumer complaints. So anything that doesn't qualify for an independent medical review, we will internally we call it flipping it to a complaint. And so the complaints are really issues related to delays in getting an appointment. If an enrollee is experiencing an unpaid claim, they are being excessive billed, either because the claim wasn't paid or they believe an excessive co-payment was assessed. If you were terminated or canceled from coverage, and this was a big thing that happened shortly after the implementation of the Affordable Care Act. There was a lot of confusion in the marketplace within Cover California, within the health plans, and a number of folks had their health coverage canceled or terminated for non-payment. And we stepped in a number of those cases and got that coverage reinstated. That has been a much smoother sailing, but that first year I was still at the help center, and it was a big problem, not only being enrolled in coverage and getting your confirmation of enrollment, but also the terminations that were occurring because some consumers weren't getting the information they needed to pay their premium payments. Any complaints related to translation or interpretation services, or trying to find a doctor, hospital, or specialist, or if your doctor is no longer with your health plan, and that is continuity of care. So continuity of care may be applicable here. If you're, let's say, in one health plan, let's say a Blue Shield health plan, and you were utilizing a Blue Shield provider, and then your employer changed your coverage to Anthem Blue Cross. You may, although you're still under Anthem Blue Cross, and Anthem Blue Cross may not have a contract with your previous provider, there may be an ability for you to continue to see that Blue Shield provider for a period of time, utilizing continuity of care. And if that occurs, you have to ask the health plan for continuity of care with that previous provider. If they deny that, you can come to the help center and we'll assess that to determine if the health plan should be approving that continuity of care. Next slide, please. So I just want to give a couple snapshots from our website and highlight how you would file a complaint or a request for an independent medical review. Off our first landing page for our website, you'll see this file a complaint, which is highlighted in red here. And then once clicking on that, you'd file or click on the independent medical review complaint form. The next slide will show you what you'll see next. Right, so the IMR complaint you can submit online. That's the fastest way of getting it to us. You can also download the forms. They're in multiple languages. So you can download, print the form, fill it out, and mail it to us or fax it to us. And then that starts our process of reviewing that complaint, contacting the health plan, and moving that issue forward. Next slide, please. So a couple of quick tips for completing the IMR complaint form so that we don't hang it up in our shop and we can move it along in a speedy process. complete the IMR form online. That's the quickest way to get it to us. If you need to download it and fill it out in handwriting, it's available in the 15 Medi-Cal threshold languages. Provide as much information as possible on the form. Include separate documents if necessary, so that we have the full picture of what the issue is. It makes it much easier for the help center staff if we have all the information on the front end to address your complaint. If not, we may reach out to you to ask clarifying questions or ask for additional documentation. So the most you can provide, if you can provide all that documentation in the front end, it is extremely helpful to our staff to keep moving that case forward. If there's an immediate threat to your health, indicate that on the form, that this is an urgent or emergent issue. We may not be able to move it forward in an urgent or emergent issue. We'll have to assess that, but that's the way that we identify that. If you don't note that, we still may identify it just from the documentation you provide. That's why it's so important to provide a comprehensive, clear, and concise explanation of what's going on and what issues you're having with your health plan. Because if you don't note it as urgent or emergent, we may still process it that way based on the information you provide. The bolded here is extremely important. You've got to sign and date the IMR form. It is giving you the release for us to contact your health plan, obtain medical records, and review your issue. If it's not signed and dated, again, it will slow the process down because we'll have to reach out to you to get that form signed and dated. We also have, as part of that package, the complaint package, is an authorized assistant form. So if you're wanting to have someone assist you in the process, you need to complete that authorized assistant form and again, sign and date it. That gives us, in our system, we note that, who that person is. So if they call in to provide more information or ask for an update on the status of the complaint, we have the authority, because you've given us that, to speak with that individual. Next slide, please. So IMR complaint, what happens next? I've already talked a little bit about this, but the figure I want to point out here is on the left. Approximately 60%, and this varies a little bit year to year, 62, 58, but hovers right around 60%. 60% of folks who submit an independent medical review request to us that qualifies for an independent medical review is 60% of the time, the health plan's decision is overturned. It's either done through the health plan reversal. So that's that issue I talked about earlier, where as soon as the health plan learns we're involved, they change their position and authorize the service, or through going through the independent medical review process where a provider is looking at all that documentation and making a decision. In between those two, 60% of the time, consumers get the service that they asked for. That's big. And so just filling out a form and submitting it to us, you've got a 60% chance of getting that service. And it is free. There is no cost to this. So this is extremely important, I think, for this group and the folks who are helping family members or advocates to utilize this process. If you happen to contact us and your health coverage is not under our jurisdiction, we will forward it to the appropriate jurisdictional agency so they can address that complaint. So it just doesn't mean we close it out and send you a letter saying, sorry, we can't help you. We do all we can to get it to the right entity so that the complaint will continue to move through the process. All right. Next slide. So another one of the questions we pose in advance: would having a health plan case manager or navigator help decrease barriers? So elaborating a little bit on that. If you were initially diagnosed with a mental health condition and a health plan assigned a case manager to you, do you believe that would help you decrease the barriers you experience? I think I know the answer to this already, but I wanted to put that out there. Okay. I didn't think we'd get a no. It's more of a question I already knew the answer to, but I wanted to throw it out there. All right, thank you. And let's move on to the next slide. So this is the contact information for the Help Center. If you have any issues with your health plan, having a challenge getting in a timely appointment, have issues or questions related to access or anything related to your health plan, contact the Help Center at 888-466-2219 or go into the department's website at healthhelp.ca.gov and you can find additional information, statistics on our IMR process. You can review our survey reports that I spoke to earlier. Those are published on our public website. Also reports related to the financial stability of health plans and medical groups. You can find complaint statistics. We have a dashboard that you can pull down your specific health plan and look at their financial status, find enforcement actions against that particular health plan. There's a lot of information on our Dmhc public website that I think would be helpful to consumers as well as just informative. All right, next slide, please. So now I want to move into the third agenda item, which is mental health parity, or MAPIA. So MAPIA was passed by Congress in 2008 and the regulations were finalized in 2013. It really is stating that, as we talked about before we started the presentation, that medical services need to be provided in parity with mental health or substance use disorder services. It means equivalent, equal, or comparable. Go ahead and next slide, please. So just a couple of quick examples. Parity and cost sharing. So let's read through this. The cost sharing, so your out-of-pocket expense to treat a behavioral health condition, is not to be higher than the most common cost sharing for treating substantially all medical conditions on an inpatient basis or on an outpatient basis. So parity sounds easy. It is extremely confusing, not only to us internally at the Dmhc, and this is what we do, but also for consumers. It is a voluminous amount of legislation, and trying to nail it down to these very simple terms is sometimes challenging. So an example of this cost sharing that would be inappropriate. Go to the next slide, please. Thank you. Is if the most common cost sharing for treating a blocked artery or their medical condition in the hospital is $200 per day, then the cost sharing for treating a bipolar disorder in the hospital, it can't be higher. It has to be $200 or lower. If it's anything above $200, it is not in parity, and we would find that out of compliance. Okay, the next slide, please. And the other area is in the parity in the day and visit limits. Day or visit limits to treat a behavioral health condition are not greater than the most typical day or visit limits for treating substantially all medical conditions on an inpatient or outpatient basis. We'll go to the next slide for an example. If there are no annual limits on the number of office visits to see your primary care or specialty doctor to treat a cold, rash, pregnancy, or other medical condition, your health plan can't limit you to 10 counseling visits to treat a mental health condition. And so if the substantially all medical conditions, that's where it gets a little challenging. Which buckets line up with which buckets? But as those buckets align, you can't put something more restrictive on a mental health or substance use disorder service than you can on a medical service. Now, this could backfire in the mental health world. And so it says you can't make it more restrictive, but it doesn't mean you can't raise up the limitations on the medical side to match. So if they limit to 10 counseling visits for mental health at 10, they could also then raise the bar to limit those services on the medical side. So it doesn't always, it may not work in favor where they would automatically lower the mental health limits. They might just raise up the medical, which again, as someone just noted in the chat room, could be sneaky, correct? So these are things we're looking at too. Next slide, please. Parity and pre-authorizing treatment services. So pre-authorization policies are not in parity if pre-authorization is required for outpatient chemical dependency counseling, but not for outpatient treatment of a cold, rash, or pregnancy. So they can't require something for a mental health condition that they're not requiring for a similar service on the medical side. Next slide, please. So in covering out-of-network care, a PPO plan violates parity if it excludes coverage of inpatient out-of-network treatment for chemical dependency when obtained out of state, but does not exclude coverage of inpatient out-of-network back surgery out of state. So again, they can't make it more stringent on the mental health side than it is on the medical service side. And so this is what we looked at when we were assessing health plan compliance with parity. So next slide, please. So how did we look at parity? What have we done so far? So we assessed health plan compliance with mental health parity in a two-phase approach. In 2014 and 15, we started through our Office of Plan Licensing in collaboration with our Office of Financial Review, and they reviewed health plans, policies, procedures, plan benefit designs, cost sharing, documentation, and worked with the health plans if we found it not to be in compliance, and worked with the health plans to bring those documents and policies and procedures into compliance. The second phase was done out of my office. It was focused mental health parity surveys, and the results of those surveys are on our public website. We went out and did 25 full service health plan focus MAPIA surveys over a couple of year period of time. And what we were looking for is to ensure that the documents that we approved in phase one were actually being implemented appropriately in phase two. So we again reviewed policies and procedures, but we also reviewed enrollee specific files. So we would ask for a log of all files related to this particular condition or this particular area. And then we would randomly select a subset of those files and review those to ensure that the health plan was following the approved policies and procedures that we gave them the approvals for out of our Office of Plan Licensing in phase one. And then we produced, again, a preliminary report to the plan, asked the plan, I gave the plan 45 days to respond to that preliminary report. And then we produced shortly thereafter a final report. Now, in the next slide, we'll talk about some of the outcomes of that. If we can move on to the next. So results. Many health plans were required to revise their policies and procedures to limit the restrictions on enrollees' access to mental health services. So this was mainly done out of that phase one approach to our Office of Plan Licensing, although we found some challenges with health plans and non-compliance with health plans through our on-site and desk level reviews through phase two. Here's a more important component for me. 7 health plans had improperly imposed cost sharing that was higher on the mental health side than it was on the medical surgical side. And so for those 7 health plans, we could have just said, hey, you're doing this wrong, you've got to fix it. We decided to take it one step further. And my office set up calls with each of these 7 health plans and told them what our expectations were and what those expectations were for them to go back and recalculate any claims where they had improperly imposed cost sharing on a consumer and reimburse the consumer for those overpaid cost sharing. And that resulted in a little over $517,000 being reimbursed to consumers in California. Several health plans were required to eliminate impermissible day and visit limits and revise prior authorization requirements that were more restrictive on mental health than they were on the medical side. Okay, next question. So here for me is the most important part, and I'm being selfish here, of this presentation, these mental health investigations. Now, what do I mean by that? In January of this year, during a budget press conference, Governor Newsom made a couple of statements related to people accessing care in California, and that there were big penalties and fines coming for health plans who were not in compliance. As a result of those statements, in addition to anecdotal stories we hear from a number of different entities and data out of our Consumer Help Center, we came up with a plan and put forth a budget change proposal, or BCP, which was approved through the 2021 state budget process. And that, I believe that budget change proposal from our department is still available on the Department of Finance's website. So if you want to go read that more in depth, you can see what we put forth. But what we put forth in that is a plan, and we haven't fleshed it out fully, and this is why I'm looking for your assistance. We put together a generalized plan of what we think we need to do to address continued barriers to continued barriers to care that are experienced by not only enrollees, but providers who are trying to provide care to patients. We've got a number of regulatory oversight mechanisms. I talked about our surveys and what we did with MAPIA compliance, talked about our help center, all the other laws that are afforded our regulatory authority under the Knox-Keene Act and Title 28 Code of Regulations. And with all of that hard work, there is still folks experiencing challenges getting care. And so these mental health investigations, which we plan on starting in early 2021, is taking a completely different approach at finding out what's going on. And so what we propose and what we're looking to do as we develop this scope of work is following enrollees, seeing if we can follow enrollee from the date that they were diagnosed with a mental health condition and looking at their medical records, their contact to the health plan, interviewing that enrollee, and looking at their entire experience, anybody that they touched from the date of their mental health diagnosis to the current day, and finding out any and all barriers that enrollee experienced along the way. And the same thing on the provider side. What challenges or barriers do the providers face in providing care to their patients? Is it that it's non-responsive health plan to pre-authorization requests? Is it a lower reimbursement? We want to look potentially at reimbursement. We want to look at the timeframes at which they respond, the time frame at which they authorize services. Is it only a couple of days, which requires more administrative burden on providers to move that forward? Talking to some providers that are not contracted with health plans to find out what barriers they feel, if we're eliminated, they would be more willing to contract with a health plan to provide mental health services. So this is we've got basically a carte blanche to do whatever we want over these 25 full service health plan special mental health investigations to find where the system is broken and then produce not only findings, but also recommendations to fix it. And so we're looking to do 5 of these investigations each year over the next 5 years. And so again, this is where I'm hoping to learn more from you than I gave to you today. And so this is why we proposed a number of questions to NAMI in advance of this presentation, because now I want the next part of the next, whenever we have half hour left, for you to give us what barriers you're facing. What can we do to make this better? And that's why I wanted my team to be on this town hall with me to hear this information. And so I'll pause there. We can go into the next slide with the Menti thing, talking about telehealth. As a provider, if we have any providers, have you engaged in telemedicine or telehealth? And I would think that would probably be higher now, given the pandemic. Okay. And yeah, I was trying to figure out what the writing was. Now I see it's yes. Got it. All right, let's move on to the next slide. Now let's talk about as a patient. So we talked about provider in the previous question. As a patient or family member, have you engaged in telemedicine or telehealth? And I'd like you to limit this to mental health. So you might have engaged in medical, surgical services, but specific to mental health. Okay, so that's about a 50-50 split there. A little bit more towards yes. Okay. Interesting. Okay. Want to move on to the next slide? Now, do you believe telemedicine or telehealth can increase access as an effective treatment option? The key there is effective. So, we are still analyzing this at the department, how telehealth or telemedicine may help networks in our assessment of health plan networks, and whether or not it helps eliminate barriers to care for enrollees, especially in rural areas. And so, we got a not for people. Okay. So possible, we got some yeses and some not quite sure yet. Okay. Thank you. Move on to the next slide. So this is, we'll just go into the general Q&A. So I'm ready and willing to take all questions you may have.
Thank you so much, Dan. I know that throughout the presentation, we got a lot of feedback in the chat box about how valuable this information is, how informative this has been. Really to echo, Jessica's introduction, we hear so much about folks having challenges with access to care. And so we're so thankful to have you here today. For the Q&A, we are going to try to do something different. I'm going to say like for all of you that have joined us today, please bear with us. We haven't done it this way before. We are going to have some Q&A options if you have questions enter into the chat box. But as Dan shared in the beginning, there are a series of questions that he and his team came up with to pose to you, to kind of hear from you about your experiences. And so we'll go ahead, we'll put them up into the next, we've got them on two different slides. There's some provider questions, and then there's some questions for family members and consumers. So we'll start here. For those that have joined us today as either a peer consumer, a patient, a family member, caregiver, you'll see on the screen there's a number of questions around challenges. What point in accessing services did you experience those challenges? What are the services that are harder to obtain? And then trying to get some feedback about the if you could change one thing, what would it be? And so if you would like, you can enter your answers into the chat box. I'm also going to, like I said, this is a little bit experimental because typically we do the facilitated Q&A, but if you would like to share from this perspective, any feedback with Dan and his team, if you want to use the raised hand option, we'll go through and open up the lines for folks that may want to share any of their thoughts or ideas about these questions here. I would ask though that just in the interest of time and the folks on the phone that, we kind of try to keep things brief, but definitely want to open that up for anyone who wants to share anything related to the questions that are up here. And so you should be able to, at the bottom, there should be some icons on your screen, raise your hand and we can kind of go through and unmute folks. But yeah, Dan, if you had anything to add to that.
Well, yeah, in addition to these questions, if somebody just had any questions related to the presentation or the help center or whatever it is related to the department, more than happy to answer those as well.
Yeah, and what we'll do is if we get to the point where we kind of get to our 3:30 hour, we'll take any remaining questions and then we can send them over to you, work with your team, and then provide some feedback to folks after if that works.
Yeah, and I can stay a little over. I don't have anything at 3:30, so if we go beyond, that's okay as well.
Thank you. So we do have one, let's see, Amparo. I'm going to go ahead and unmute you. Let's see. There you are. How are you?
I'm good. Thank you so much for taking my question. So I am a peer and person with diagnosed with a severe mental illness, and I'm also a mental health advocate. Some of the challenges I'd faced, which was specifically with Kaiser, was getting connected to therapy. So it took me over 8 weeks to finally see a therapist. And it wasn't until I had done a complaint that I actually got to see one. And I guess my point is that once I had filed a complaint, Kaiser followed up with me like 4 times, twice in writing, a few follow-up calls. And it just really seems like there's so much emphasis once you've done a complaint to make sure that you're okay. But at the point where I was at my lowest and I needed immediate care, and I think if I wasn't doing this for a living as a mental health advocate, I would have given up. That could have resulted in suicide or something like that. And so for me, how can we hold insurances accountable to respond when someone's at their lowest? And I know that he meant that Mr. Southern mentioned that if you need someone to guide you, there is that, and I think that's great. But for someone who doesn't know, like I was one of the people that had never heard of this organization. How can this organization let all, or how can they ensure that insurances kind of don't let it to get to a complaint, so that it doesn't have to be as severe as it could have been, like for someone like me?
Yeah, and thank you, Amparo, for that information. And this is the information what I wanted to glean from participating in this town hall, because we hear the complaints we get to our help center. We see things when we go out and do our medical surveys, but there's a piece missing. And it's this piece right here of walking through your explanation of what challenge you faced. That's something we put in, and that's why my team is here, to gather this information to help us develop our scope of work for these special mental health investigations we'll be starting in 2021. The goal of that is to identify these barriers that we may not have been aware of before, and then find a solution to fix those. Whether that may be through, it may require more statutory involvement, or just us looking at things differently in our different offices. We're not sure, but gathering this information will help us guide where we're going to go through these investigations. So thank you for that information.
Thank you. So again, if you want to have any, if you want to share anything with us today, you can go ahead and use the raised hand option. You can type into the chat box that you'd like to share. We can unmute you. There is a bunch of stuff coming in through the chat box, a lot of feedback from folks about their excitement over the sound of these investigations, some feedback about things that would make it easier would be appointments same day for therapy and a doctor or psychiatrist. Another person voiced some concerns around the rapid change of mental health personnel who engage with clients. And let's see, another comment here, change the HIPAA laws and California reciprocity. These 2 items have been held by consumer advocate groups, and they are huge barriers to family members who want to help their adult children, even more so with COVID-19. See, and we'll provide all of this feedback to you and your team too. And I know that there's a lot of information in here for you as you're planning kind of the
I'm seeing the 86 comments pop up through the chat. We'll make sure we capture all that. It's important.
Yeah, absolutely. So so I don't know if we can also switch to the next screen too. There's some questions on here for folks who are providers, similar to some of the questions that we're posing for family members. Let's go ahead and move to the next slide. So that way, if there are any providers on the call, they can share in. And so for the providers, it's what's one change in the health industry do you think that would most benefit access to mental health care? When trying to get mental health services for your patients, what steps do health plans make you perform that you feel are unnecessary? And then if you're a mental health provider who does not contract with health plans, or providers who are unwilling to contract, what could health plans do to encourage providers to join a contracted network? Reimbursement, decrease administrative burden, etc. So if there's any folks that are joining us today from that perspective that want to share, we can take your comments in the chat box. We can also you if you'd like to share some of that with Dan and his team right now. While we're waiting for that, let's see. So there's some other comments here about transportation being a barrier to access to care. We do hear that a lot. I remember there was an individual who shared with us that for them to get to an appointment down in the LA area, it was 3 or 4 different transfers. It was basically an entire day getting there and then getting back. And so we hear that a lot. Transportation. We also hear a lot about, you know, the cultural competency piece, having providers that look like you, that speak your language, that understand what it means to receive care within different cultures. So notes here. See, the family advocates had a slide presentation explaining to clinicians in the county behavioral health system how much better things go for the patient when there's more involvement with the family. We hear that a lot from family members too, is how to include family members in their loved ones' care, having access to being able to support them through that. Another individual here shared, let seniors know that Medicare will pay for therapy with small copays. I think that's very relevant when we're talking about access to care for older adults, for seniors, those who are isolated.
Right.
So let's see. Check here.
I just want to say this, I'm excited about this collaboration with your organization. And I think it will be very helpful and I will be in touch with Angela probably more than she'll want me to be.
No,
but if anybody who's attending this today is willing to assist us, who is either a family member, a mental health patient themselves, and is willing to sit down with us through an interview process and walk us through your experience, please let NAMI know, because I will be in touch with them to try and find those folks. You know, especially those who have cultures outside, you know, the general English speaking population. I think the challenge for us is finding folks who are willing to speak to a governmental agency in this day and time, and knowing that we're here to help. And so breaking that barrier down that we face and working with English as a second language consumers. So we're looking for participants to help us as a collaborative process in these mental health investigations.
That's really exciting. Thank you. I know that we hear a lot from our folks. Like I said at the beginning, we hear so often about access and how difficult it is. I know I can speak from personal experience, you know, what it's like to jump through the hoops. And I think for those of us, you know, for some of us that are here today, I think our journey is a little bit easier because we've been educated on what our rights are and our responsibilities are. We've, you know, been able to interact with folks like you and other entities that tell us, you know, here's actually what you're legally and you know, what your plan should be doing for you. So we know to push through. But I do suspect that there's a lot of folks that when they hear that first no, they just sort of give up and back away. And so you know, I'm really excited. I know our team is really excited about these investigations and, you know, really being able to kind of unpack the system and see, you know, at what point things are broken and the recommendations that'll come from that to really help increase access to care, which, I mean, just that alone, there's just so many amazing outcomes that will come for, you know, individuals and family members just by being able to get in the door and get the care that they need. So I've got a lot of folks that are sharing in the chat box that they'd be willing to share. So we'll definitely connect you with them as part of this effort. Let's see. Barbara shared again, it says, reassures my clients. And then it reassures my clients and then I am informed about the next steps required, yet insurance won't cover that. It might all day, but the payoff is that we get better outcomes, reduction in emergency services. Another individual shared, in my experience, a lack of family that live close by that can assist in healing is a major point to help the recovery. Another one of our advocates shared that they work on one of our NAMI resource lines and they listen to, you know, family members, you know, all day talk about this issue. Let's see, there's another question here that might be something we can ask. How about having a local mental health ombudsman to feed info to you? Have there been any conversations about that?
I haven't spoken to any local ombudsman, but open to obtaining information from anywhere and everywhere at this point. We through that budget change proposal, we were afforded 2 positions and some contracting dollars to bring in clinicians to help us with this effort. We'll also be tapping into some of our special investigators in our Office of Enforcement. But we are just starting this. We literally just filled within the last week our 2nd position, and both of those folks, I'll call them out, Tammy McCabe and Christian Jacobs, are in attendance here today because they will be the main runners and drivers of these mental health investigations. And so all of this information helps us build the appropriate scope of work, which I think will change appropriately as we do 1 or 2. We might learn something here and make some changes. To me, it's going to be a fluid process, not a concrete process. So as we learn new things to go down a different rabbit hole, we'll do that. So at the end of this thing, and I want to assure people, the goal here isn't to do 25 over 5 years, and you have to wait for 5 years to get some impact or improvement. As we note things that seem to be common denominators, what can we do now to address those? Putting forth that information to whoever it might be that can help us eliminate those barriers.
Great. So there's another, let's see. So some stuff is coming through the chat box here. Some of the issues are HIPAA and the inability to get SMI hospitalized for effective life-saving care. Another question that came in is, could we get a list of the 25 services?
It's a 25 full service health plans. So it's 25 health plans, commercial health plans.
Okay. And do you have a list? We could share that with our folks just if they wanted to.
Yeah.
Okay.
We could put that list together.
And then let's see, what else is, there's a couple more. So you should include contacting adult residential facility owners. It says our social worker who works with our HOT has been the very best decision that we've ever made. Another one here says more provider training on suicide prevention. So looking at the time, and I don't have any hands raised here, we're getting a lot of great feedback. And as usual, we'll share my contact information. I know your contact information is on here for folks who have thoughts or questions that come up after the fact. So if you think of something, or if there's more information that we can provide to you, or get in touch with Dan to provide to you, I'm always here. We'll pop my email address up at the end of the presentation. There was one question that just came in that says, do you have any position papers regarding HIPAA and AOT? And then let's see.
Yeah, I'll have to look into that.
And then need to contact board and care facilities, especially the operators. So we'll collect all of these. We'll get you all the information, the service provider plans, all of the things that are in the chat box. We'll follow up with everyone after the session today. We'll also have a recording of this for folks that were unable to make it. And then we'll go to the next slide, just a couple of small things. For those of you, we've got our link here for our evaluation of today's session. We always love to hear how we're doing and any thoughts you have on, who we can get on the schedule, any thoughts that you have about the format. And then if you want to register for any of our town halls, the link is here as well, namica.org/town hall. Our next one will be on September 15th, and we have the California Pan-Ethnic Health Network. And then on September 29th, we have the California Alliance of Child and Family Services. And then we're lining up our folks for October, including BHBC, which is the California Association of Local Mental Health Boards and Commissions. So we are moving into the fall. We're going to continue these series discussions. We also have our conference coming up. So for those of you that haven't registered yet, our conference is online this year. Our link is here on the screen. You can register for free. It'll be on October 12th and 13th, and we have a full slate of conversations, presentations, workshops. It's really going to be an amazing few days, and so please go ahead and register for that. And our Advocacy Day, last but not least, that's next Thursday. So all of the links to of these events are here in the chat box. Our wonderful team behind the scenes, I just want to give them a huge shout out. Brianna and Ragini that have helped with getting the information to you in the chat box, that help maintain the slides. Just there's no way we can do it without their support. So thank you to our team because they're awesome. And so for all of you that were here today sharing information, asking questions, you know, this is just the first, as Dan said, you know, there's a lot coming with their mental health investigations and their team wanting to learn more from all of you. So we're really excited for the partnership that we'll have with them, connecting you, share your stories and experiences, your thoughts and your solutions on, you know, what we might do to increase access and identify the areas where, you know, it's definitely a work in progress. So again, if you have any other questions, thoughts, things that you want to share with us or Dan's team, my email address is here up on the screen. You can reach me anytime, and we'll gather the information here in the chat box. We'll get all of the things that we said to you back out to you when we share these materials, and we'll definitely keep in touch with Dan and his team, and time for them to come back. Maybe as the investigation project is getting off the ground, they can come back and kind of touch base with us and let us know how that's going. And I think with that, I know that for those of you, I said it last time, I'll say it again, I know school is starting. And so for those parents that are working out all the kinks with distance learning and managing work and home and everything in between, thank you for carving out time to be here with us today. I wish all the good vibes for all of you. And then for everyone that's joining us, just generally, I hope you're all well. I hope you stay well. And I hope that you all have a wonderful day, and we'll see you at our next session. Have a great day, everyone.
Thank you.
Thanks.